Every year, more than 100,000 people are diagnosed with leptomeningeal cancer, and yet we do not have the tools to prevent, diagnose, or treat this disease. The Leptomeningeal Cancer Foundation is here to change that. Working with medical experts, researchers, patients, and their families, we will raise awareness, educate patients and healthcare providers, and support research. Please visit us at lmcancer.org and follow us on social media. We are here to support you and ensure that you never feel alone. Hi, everyone. Welcome to today's webinar. We are so grateful that you are taking the time out of your day to join us. I'm Helene Bader. I'm founder and president of the Leptomeningeal Cancer Foundation. And as many of you know, I started this foundation in honor of my son, Theo, who died at the age of 17 from leptomeningeal cancer. And from this terribly difficult experience, I realized how little information and education there was available to people with unexplained symptoms of LM or diagnosed with LM. So I started the foundation to help others educate patients, caregivers, and healthcare providers, and provide valuable resources. Before we jump into the introductions and presentation, just a few things. We do have live captioning available, so please use the closed caption icon box to turn on captioning or click the view full transcript under the captions and translation panel. Please use the Q&A function to ask any of your questions. You can enter them as they come up, and we will get to as many as possible at the end of the presentations. If you sent one in during registration, don't worry, we have those included as well. And please know that our presenting doctors cannot provide medical advice on this webinar. So if we get any questions that are specific to a personal situation, we won't be able to answer them. And on that same note, just a reminder, the information you hear today is not intended as medical advice or as a substitute for medical care. Please speak with your doctor about any healthcare decisions and your personal care plan. So thank you for understanding. So as you know, today we are focusing on lung cancer and leptomeningeal spread, and we are really lucky to have two amazing doctors with us. First, Dr. Seema Nagpal is a neuro-oncologist at Stanford Healthcare. She's also a clinical professor of neurology and neurological sciences and a clinical professor by courtesy of neurosurgery at Stanford University School of Medicine. She treats both primary brain tumors as well as metastatic disease to the brain and nervous system. Her research concentrates on clinical trials for patients with late-stage central nervous system cancer, and she has a special interest in leptomeningeal disease, a devastating complication of lung and breast cancers. Welcome, Dr. Nagpal. We also have Dr. Mohana Roy with us today. Dr. Roy is a medical oncologist at Stanford Healthcare and a clinical assistant professor of medical oncology at the Stanford University School of Medicine. She has expertise in lung and thoracic cancers and has a broad clinical interest in oncology. Dr. Roy became an oncologist because of her passion for patient care. She is committed to being a clinician and is focused on improving the patient experience. She is the Associate Medical Director for Quality at Stanford Care Center from 2022 on. Dr. Roy's interests include access to clinical trials, quality improvement, and improving care delivery. Welcome, Dr. Roy. And now I will turn it over to Dr. Nagpal to begin.
Great. Helene, thank you for inviting Mohana and I to be here today. I'm really fortunate that I get to work with her directly in the care of our patients who are very complex and very individual. So it's wonderful to have a partner who's thinking just as hard as I am about every one of them. So our talk today is leptomeningeal cancer. We'd like to do better and a lot faster, and I think that's why a lot of you are here today. So I'm going to start at the beginning. What is leptomeningeal cancer? It's really cancer on the coating of the brain. So the same space where you may have heard of meningitis, which is an infection. When cancer cells get into this space, it is called leptomeningeal cancer, leptomeningeal disease, LMD, lots of different names. Broadly in cancer patients, this occurs in about 5 to 8% of patients by the time the end of the cancer journey has happened. Patients who develop leptomeningeal cancer can have nausea, vomiting, headaches, seizures, but more often than not, patients will come to Dr. Roy and have some very nondescript complaints that might include low grade of all of these things, or a chin that's numb, or something like their hand is now numb. Because it can really show up in many different ways, diagnosis is frequently missed until patients get more symptomatic. In fact, we think it is present at the time of death in almost 20% of patients who have any neurologic sign or symptom. And that data is actually really rather old at this point. It's half a century old, so maybe even more than that as our systemic treatment has gotten better. Unfortunately, there is no standard of care for patients with leptomeningeal cancer, but creative care can really do a lot to enhance quality and quantity of life. We do think that the incidence, or how often this happens, is increasing. You can see just from 2001 to 2009 within non-small cell lung cancers, this really has increased. We think patients are now living long enough with good systemic therapy that the brain and central nervous system kind of are the last place sometimes this ends up. There is variable drug activity in the central nervous system, so that may be less protected than other parts of the body. There's also increasing sensitivity of all our diagnostics. So a CT scan doesn't pick it up that well, but an MRI will. And now that MRI is more standard, we may just be seeing more. We also think that certain treatments may be increasing the incidence of leptomeningeal metastases, obviously inadvertently, but these are things that we're learning the more we study and look for leptomeningeal metastases. So what do I mean by that? So one example that we can show is that for patients who have had brain surgery to remove a metastases and then have CyberKnife, Gamma knife, or stereotactic radiosurgery to that spot post-surgery, any patient who's had that kind of therapy may be at higher risk for developing leptomeningeal metastases in the future. So you can see the breast cancer risk goes up substantially at 2 years, and so does the non-small cell lung cancer risk. Now, does that mean we should stop doing what we're doing? The answer is no, because that's still the best treatment. It just means we need to be aware and monitoring patients for symptoms so that we can intervene earlier. So within non-small cell lung cancer, the incidence used to be reported as 3 to 5%. But again, I think this incidence might be older. Some studies are quoting 5 to 10%, and Memorial Sloan Kettering's most recent data shows at 5 years, it's really 12 to 13% of non-small cell patients will develop leptomeningeal metastases. So you can see EGFR and ALK patients, again, living much longer now because of targeted therapies, eventually may get this complication. When I started as a neuro-oncologist, the median overall survival in this group of patients was quite short, meaning all comers lumped into one space on the matter of weeks. And I know this number has moved out quite a bit, so we're going to show you some information about that. Brain metastases, solid ones that grow as a ball, are much easier to diagnose. MRI is standard imaging for patients with leptomeningeal metastases, but has limitations, which I'm going to show you in a minute. So both Dr. Roy and I use a combination of all these things and clinical experience to really tell us if a patient has developed leptomeningeal metastases and if their treatment is working. So what you see here are two MRIs. One of them is cut like a crown, so we call that a coronal section. You can see there are two arrows there, and what you kind of see is smudgy white stuff. And so this is actually a very profound MRI with leptomeningeal disease, even though it doesn't look like it, but you can see this is not a ball, right? It's very smudgy. So your neuroradiologist has to actually be looking for it, and so does your oncologist. Similarly, on the right-hand side, that's actually one of my ALK positive patients where this was the only slice of the MRI where the outlining of the brain, of the wrinkles of the brain, shows up. And so again, you have to be on the lookout for it and listening for your patients having symptoms. Sensitivity of MRI overall is thought to be 70 to 85%. And its specificity, now that there are other things happening, including IO drugs or immuno-oncology drugs, it's not super specific. If you've been exposed to an immuno-oncology drug recently, your MRI can look a little bit like that from inflammation too. So another piece of diagnostics is very important, and that is the lumbar puncture, where we take fluid from the low spine, below where the adult spinal cord ends, and we look at it under the microscope. That process is called cytology. Unfortunately, it remains a pretty insensitive test. So a single lumbar puncture may detect only 50% of patients with leptomeningeal cancer. So what we have been doing is actually multiple lumbar punctures sped out over space and time to increase the sensitivity of finding those cells. The other thing you and your doctors can do to increase that is to make sure that when they send the fluid, they're sending at least 2 or 3 teaspoons to the pathologist, not 1 cc, because that doesn't tell us anything, reduces our ability to really diagnose accurately. The other things that we can do are some new diagnostic tests, also kind of broadly known as the liquid biopsy. So this refers to looking for circulating tumor cells as well as cell-free DNA or cell-free RNA in the cerebrospinal fluid. We think that that might be more accurate than blood because we're really talking about stuff that's right next to that fluid is right next to the coating of the brain and the spine. It is also collected through lumbar puncture for some patients who have an Ommaya reservoir. They will be collected through an Ommaya. And right now, there are really kind of 3 players in this space, but the list of names may, go to infinity as more and more companies get into this. The first test I'm going to talk about very briefly is called C-Inside. That test actually takes this circulating tumor cells and tags them and puts them down on the slide so you can look at them with your eyeballs and count them. It's very useful. We don't have access to this test right now, but we think at the beginning of 2026, this will be online again. The data to support this test does look like it is more sensitive than a standard lumbar puncture. So, and then moving to the Belay test, that test looks only at cell-free DNA currently, but also is quite sensitive to seeing if there is DNA floating around in your spinal fluid. It should not really be there if there's no cells in the spinal fluid or in the brain. So that these 2 further down tests become a bit more tricky. If you also have a ball of metastases in your brain, the cell-free DNA could be coming from there. So how exactly we use these tests is still all in motion. Both Belay and Menarini do cell-free DNA, and as you can see here, the sensitivity, meaning how often we can pick this up, is increasing over the gold standard cytology. So these tests actually are all available. If your clinician calls the company, you can get the kit. So you don't need to come see Dr. Nagpal or Dr. Boir or Dr. Kumtekar, like 3 or 4 folks who are well known around the country for doing these tests. Your doctor can get these if you contact the company and get the kit. So treatment and management, once we know it's there, these are sort of some classical principles, but things are changing. So historically, CNS metastases have been associated with worse prognosis. More recent studies show this not necessarily the case. Older systemic chemotherapies, we used to talk about this as limited access to the central nervous system. It really is limited activity in the central nervous system because what we're learning, and you'll see later with Dr. Roy's talk, is that big molecules are getting into the central nervous system. So this isn't about size. It's not about a wall. It's really about how active is this in this space. Radiation techniques have also been changing. They achieve local central nervous system control, but comes with a set of side effects. So you want to make sure you're talking to your doctor about what those might be. So here are a few of our current managements. First is radiotherapy or radiation. CSI refers to craniospinal irradiation. I'm going to show you a picture of what that looks like. And you can either use photons or protons. These are 2 atomic particles and they have slightly different properties. Systemic therapies like chemotherapy, anti-angiogenic therapy, immune therapy, and one that we kind of slid off of the back here is antibody drug conjugates, which I think Dr. Roy is also going to talk about. There is a nice list here of targeted therapies, but just for 2 of the common mutations. This list is also grown in non-small cell. We now have NTRK inhibitors, we now have RET inhibitors, we have MET inhibitors. And honestly, if we listed them all on one page, it would fall off the bottom, which is an amazing place to be. We also do perform intrathecal therapy on a few of our patients selectively, and this is a list of some of the drugs that can go in there. Additionally, we actually can put in some of the antibodies like intrathecal Herceptin. All of them can be used together or in combination as well. So radiation therapy. Whole brain alone in this disease doesn't seem to make much of a difference when you only treat that spot in the body. And why is that? Well, the brain and the rest of the spine are all connected by this river, so the rest of the river still has cells in it. If you are going to do whole brain radiation, I think the lesson here is that you need to think about how you're going to treat the rest of the river. And that's where Dr. Roy and I really work together to figure out, okay, if we're going to do whole brain, what do we do next? We can't just do whole brain and kind of leave it, because otherwise we're not making much of a difference. So if we choose to treat the whole spine with radiation, a lot of times we're sending our patients to get proton craniospinal radiation. On the right-hand side here, you're going to see the difference between a plan with photons, which is basically electrons, versus protons, which are a heavier particle. Why did I even talk about that? Because the heavier ones, theoretically, when you shoot them, they stop a little earlier and kind of more where you want them to. So what you can see on the radiation plan is that the red is the dose that we want. Anything a little bit colored is dose that is sort of fall off, but we just have to deal with the fact that it's there. You can see the protons, there's hardly any dose in the belly, in the lungs, and that's what we want or would prefer, we think. And then photons have a little bit more in those places, so more side effects in those spaces. Why don't we use this like on everyone? Well, in adults, CSI, protons or photons can cause irreversible bone marrow suppression. So if you've got disease elsewhere in the body, Dr. Roy is going to have a hard time giving you more chemotherapy. So we got to be real thoughtful about when and how we use this tool. And in addition, at least at our institution, we have a lot of people who are thinking about how is this going to affect my brain and my cognition over time. Proton CSI is still whole brain radiation. So those concerns still stand for our patients. This slide just kind of demonstrates, you can see that patients who got protons, as opposed to just doing bits and pieces of the spinal axis with electron radiotherapy, do better. So if you're going to do it, I would say for now, try and get to evaluation at a proton center. And now when it comes to giving you drugs by your mouth or an IV, I'm going to hand it over to Dr. Roy.
Thank you, Dr. Nakpal. And I'll just echo her sentiments where, for better or for worse, we have each other on speed dial and lots of out of work hour communication. Because as you can tell, with how subtle these findings can be and things can change rapidly, you really need that partnership. So again, a lot of respect for what she just went through in a lot of detail. And what I'll be really thinking about is exactly the point where she left off. Let's say we actually did that whole brain radiation. That is, I truly describe as a band-aid. It's a very fancy band-aid, but it is a band-aid. And I really have to keep thinking about what are we doing with this lung cancer? It's coming from the lungs. It is not brain cancer. And so there is an origination point, and what do we do? And this slide, I think, is a really nice reminder that lung cancer has become, thankfully, a very exciting place to practice. And we are truly making survival benefits, which is really what we want to focus on. You know, as far as when we're having that initial prognosis conversation, I do discuss with my patients my concerns, of course, with the seriousness of this disease. But once we get that out of the way, we're looking to the future, right? We're looking to how do we improve care. And this slide really just captures the breadth of, thank you to Dr. Nagpal and colleagues for looking at this, where patients with non-small cell lung cancer, which is again what we'll focus on for this talk, there's really been a pretty significant improvement in survival, even with this leptomeningeal carcinoma or disease, where we really would be talking about limited to almost no treatments in the recent past. And so I'm going to clarify a few terms that we already have used just to make sure we're all on the same page, and then dive into targeted treatments. In general, most lung cancers are non-small cell lung cancers. We estimate that's about 70 to 75% in general of lung cancers. So we're really talking about non-small cell. Small cell lung cancer, just briefly, of course, is its own entity and disease. We use many similar treatments, but in general, small cell lung cancers do not have these targeted mutations or treatments. And so for non-small cell lung cancer, EGFR mutations, which occur anywhere from, the estimates are as low as 15% to 20% in the lung cancer population, up to, in our clinic, some days it feels like 50 to 80%, because we live in a place where people have not had as much of a smoking history. There is a predominance for younger age and Asian populations, all of which fit the Bay Area quite well. So something that our clinic is very familiar with. So just with that context, when we're talking about EGFR, ALK, ALK, ROS1, these are targetable mutations in non-small cell lung cancer. So now that I've given you a little bit of baseline to kind of catch you up to where we are, EGFR disease really is our kind of poster mutation in understanding this disease better, because it is actually more common and also has been known for the longest. So we have a lot of data. So here you're seeing two curves from what is called the FLORA trial. This is actually now quite old. It feels recent, but from 2018, where a third generation tyrosine kinase inhibitor, a TKI called osimertinib, the brand name is Tagrisso, does enter the brain, to Dr. Nagpal's point, and has really changed our practice with this disease. So, normally, again, we would be worried about the brain really as a separate compartment. But now with a drug like this, we are using it very frequently as first-line treatment, definitely. And then we are seeing that the progression-free survival on the left for CNS, so central nervous system, is improved with that blue line with osimertinib compared to even not just chemotherapy, but older pills that were developed before. And that is really a major advance in our field. So we are really thinking about this as a systemic treatment, not for the body just alone, but to the brain. There are two trials I'll mention briefly in the EGFR space. One is something called the Bloom trial. The reason we like to mention this trial is there are not very many trials in LM disease and non-small cell lung cancer. So when our colleagues come together and do a phase 1 trial specifically at this, I think we have to talk about it. So this was a phase 1 study looking at the same drug, osimertinib. It was given at a double dose than what is FDA approved for non-small cell lung cancer. So instead of 80 milligrams, it was given at 160 milligrams. And the response rate, that is one of the markers we use for success of these drugs, was 62%. And that is actually quite high in our world and what we look at. Traditionally, even with just chemotherapy in the body, we may quote a response rate around 20 to 30%, just to give you a comparison. So having that level of activity in specifically LM disease was very encouraging. And this is definitely an approach we use for EGFR disease. I did want to highlight one thing Dr. Nagpal mentioned is sometimes I think patients are understandably quite surprised or even disappointed at how much of this is art and not science. And so it would be wonderful for us to use CSF and MRI to pinpoint exactly the LM, but it really comes back to the principles of medicine. It is symptom checks, lots of symptom checks, and really being honest with your doctors. And so I just wanted to kind of really hone that point in as we show you all these fancy graphs and things like that, that we truly guide treatment with symptoms. And so with EGFR disease, we're on the lookout for, again, those subtle findings. Sometimes it's just a migraine headache at the end of the day, but we still do that evaluation to make sure we're not missing this. And again, with osimertinib now, we are seeing prolonged overall survival even in this population with leptomeningeal disease. This Bloom study also looked at duration of response. I won't go into too much detail about this T790M unselected cohort, but just to mention that this is a specific type of the EGFR mutation, and we were really seeing prolonged responses even in, again, harder to treat populations. And then one other trial sounds similar, not Bloom, but Blossom here, just to highlight that even 80 milligrams, which is our standard dose, actually works quite well. And again, we will decide on that 80 milligrams versus 160 milligrams with working with Dr. Nagpal and also, of course, the person who's taking this drug. As far as just targeted drugs in general, again, focusing on EGFR, I did want to show you just a brief example of how at Stanford we are hoping to continue to keep this going as far as new techniques and ideas. So this is actually a paper that's about to be published by one of our fellows who looked at the idea of pulse dosing osimertinib, the same pill we're talking about. So the idea that instead of giving just a high dose all the time, why can't we give an extra high dose to essentially get into the brain? There is, and to Dr. Nagpal's point, brain activity, not truly entering the brain. And so this showed that just, again, very small number of patients, but that many patients who had even received the prior same drug or even the 160 milligram dose, we saw some benefit in some patients. And so again, this is not any way a take-home message that everyone should do this pulse dose, but just as examples of mechanisms we're looking of in understanding how these targeted drugs work and how can we systemically treat people, again, both brain and also the rest of the body. With this targeted treatment, I did want to make two additional points in this EGFR space. So the first one is that this pill, osimertinib, has been the standard of care now at least for 4 to 5 years as the first line treatment, but we're continuing to improve on that. One study that I will mention is called Flora 2. You'll recall that I just went through that Flora, that first slide I showed, and that actually is showing that adding chemotherapy to the pill may have really kind of a prolonged survival benefit. We used to think of sequencing a lot, and we still do, to be honest, to say, does it matter for you to get all these drugs at the first get-go, or is it okay to kind of line them up one after another? And so with certain patients, definitely, if not just with leptomeningeal or CNS metastases, but also other risk factors, we are adding chemotherapy upfront. And then the second part I'll mention are new types of drugs. So amivantamab is a drug that is EGFR and MET directed, and that is the next step of what we use in treatment when the osimertinib we think stops working. The reason I mentioned that is there was another trial combining amivantamab and something called lazertinib, lazertinib, and that is a cousin actually of osimertinib. They're very molecularly similar. I mentioned this as another example of combinations of drugs that are now actually showing improved CNS activity in general. We usually do not have leptomeningeal specific data, but we use this kind of interchangeably when we're making decisions for our patients. And so with that, I'm going to briefly mention that there are other mutations, as I mentioned. So one is ALK positive. So ALK is probably the second most common mutation we see. And when I say common, I should note that in the general lung cancer population, this is still quite rare. So this is usually estimated at around 5% of all lung cancers. But we do have a pill such as lorlatinib, where we are again seeing highly CNS active disease with CNS active activity, with this drug. And then again, this is actually one of Dr. Nagpal's slide in highlighting that we are getting some more leptomeningeal data. We're again using data from brain metastases and leptomeningeal kind of interchangeably, but we do recognize them as different entities. So the Pearl study is a study that hopefully will, again, small numbers, but really are trying to distinguish the brain metastases cohort and the leptomeningeal cohort and see how this drug in ALK positive non-small cell lung cancer, how that is going to work at the standard dose. And then we do our best. as far as with the long list that Dr. Nagpal mentioned, here are 3 different pills, again, or pill combination, encorafenib binetinib for BRAF, selpercatinib for RET, and adagrasib for KRAS mutations. This is just a snippet where we use the data we have for brain metastases and CNS activity to decide if those patients do develop leptomeningeal disease, what dosing, schedule, and what combinations make sense for them. And with that, I'll highlight another colleague's work where in the brain metastases space, we are thinking about, well, if these pills, some of them are so beneficial potentially to the cranial nervous system, can radiation be deferred? And so this is work from my colleague, Dr. Nathaniel Mayal, who looked at, I will acknowledge this is not leptomeningeal specific at all. This is really looking at brain metastases, but giving you an idea of the type of work we're doing. Can we defer radiation treatment? Usually when we see brain metastases, we again think of that brain as a separate compartment. So our general focus and management has been to use usually radiation more than surgery. Surgery does have a role as well to really target those mutations and metastases, excuse me, while we figure out what we do for the rest of the body. And his study, done actually with UC San Francisco, University of Colorado, and then us at Stanford. This was a retrospective, meaning looking back of patients we had treated, really looking at if they had an EGFR mutation, an ALK or ALK mutation, could we actually have just the pill alone and not need to do radiation, at least initially. Just to give you an example, now you're going to get familiar with some of these pills. He and his team looked at osimertinib, that's the EGFR drug, and alectinib, that's another ALK drug, and looking at kind of what were the demographics in this small cohort, and they were fairly similar as far as we could compare them. In both the EGFR and ALK positive groups receiving radiation, most people did receive what's called SRS, or targeted radiation to that brain metastases, although 20% did get whole brain radiation. And I think what he found is actually confirming of our practice is that for both EGFR and ALK mutation, there was really no significant difference as far as time to any cancer growth or progressive disease if there was pill alone or initial radiation with the pill. These curves are pretty close together, so I don't tend to overinterpret them. You might argue that there actually is a slight benefit of using the pill alone in the EGFR cohort, but this really kind of confirms that for brain metastases, if they're not causing large symptoms, we actually likely usually start with the active CNS drug first, and then we do, of course, follow up with MRIs and symptoms very closely to decide if someone needs radiation. And with that, I'm going to pass that back to Dr. Nagpal for finishing out with intrathecal treatments and how we decide those options.
Thanks, Dr. Roy. So I'm going to cover a lot of these slides very quickly because I want to make sure we leave time for questions for everyone. So intrathecal therapy refers to, instead of putting a pill in your mouth or an IV in your arm, actually putting chemotherapy or some targeted therapy directly into the central nervous system in the fluid space. To do this using a small port, just like a chest port, but put into the fluid space in the center of the brain. That surgery generally is 1 or 2 hours long with a 23-hour stay at our hospital. So it is a brain surgery, but it is, of the brain surgeries, one of the smaller ones. We can put a number of drugs in here, but compared to the number that we can give you orally or IV, it's actually rather small. We have used it in pemetrexed in a few patients. I do use caution in these because it's a huge commitment for you as a patient and a family to come for most of these. So this is 1 or 2 times a week, at least for the beginning. And whenever we put something directly in your central nervous system, I have the capacity of making you sick from your central nervous system. So I could actually give you meningitis. These are the reasons that Dr. Roy and I talk really closely together about which patients this might make sense for, and and where I could actually just hurt someone. So pemetrexed is one of these drugs. More commonly, I use topotecan actually because it's much better tolerated in my opinion. Methotrexate and cytarabine you can use. We just don't use them all that often because they're not used systemically actually all that often for lung cancers in general. And then in our practice, we also use intrathecal Herceptin, which targets HER2, which is seen in a small number of lung cancer patients. So again, this is something that you want to really talk to a subspecialist about before embarking on. Can it be helpful? Yes, but it's a lot of work for everyone. So do we think these things are safe? I'm just going to highlight here what does leukoencephalopathy means. It means turning white of the brain, which I tend to think of as like a scar tissue. It means everything slows down. And I mean memory, speech, walking, all these things. So 10% of patients getting this, that to me, that's something worth talking about before we embark on this journey. And what about immunotherapy? What if I give that to you either this way or through your vein? Well, I think jury's out on this one. I think Dr. Roy and I would really talk about it if your cancer had high PD-L1 expression. But when you kind of lump all comers, it's not clear that it's super helpful. So again, talking to someone who really knows the disease in and out is very important before making a treatment decision. There are some studies coming down the pipeline that are going to be very interesting for patients who weren't represented by the targets that we talked about. So one of them is HER3, which we actually think is also plays a high role or an elevated role in brain. And this is a drug antibody conjugate that targets HER3. This study in the systemic setting did not initially meet its benchmark. However, specifically in the leptomeningeal disease cohort, you can see some pretty neato numbers here. On the next slide I have here, the median overall survival here is actually quite high for a study group in leptomeningeal metastases. So this is a drug we're going to keep our eyes on. And just to reassure everyone that we are thinking about this all the time, and actually we have many colleagues across the country and world who are as well. This is a small sample of the studies that are coming. And you'll notice that not all of them are for targeted therapy. So diferoxamine is all comers with leptomeningeal metastases. So is the QBS study. Many of the radiation studies, doesn't matter what target you have. And there are other drugs where we're learning how to use them, such as the TROP2 targeted drugs, which TROP2 is actually kind of universally expressed, and therefore we don't test for it as a marker. And those patients may also get benefit with the next generation of drugs that are coming out for that. With that, I'm just going to say that Dr. Roy and I are looking into the future, and we are really hopeful that this list will fall off the bottom, as I mentioned before. Careful use of these drugs can really make survival longer, can make survival better. And if we can delay or avoid other more toxic treatments, that's also a bonus. And I think that's all the slides we have.
Excellent. Well, thank you both so much. This was really helpful. Such good explanations. Remember, if you have any questions, please add them to the Q&A, just so you know the questions can be anonymous if you don't want to add them in with your name. We do have quite a few questions that came in earlier, so I do want to jump right in. The first question I thought that would be interesting for a lot of people on this webinar would be, what type of monitoring should be done for a stage 4 non-small cell lung cancer patient with or without a history of brain mets? Is there a schedule that should be followed, or what should they be doing to pay attention for this?
Yeah, I can take that. So we usually use CT scans essentially every 3 months. I do like to, even though this is a brain focused talk, I'd like to kind of talk that PET scans are not always better. I think that's sometimes a misconception, and PET scans can sometimes lead us a little astray. And so, when someone has lung nodules, for example, and we're truly looking at millimeters in size, a CT scan actually is a better quality scan. Now, there's lots of rules for PET scans that I'm happy to get into, and we do alternate to make sure we're not missing things that might be CT occult, meaning we can't see them on a CT. Going into the brain, the standard usually is an MRI brain once a year, regardless of mutation status in lung cancer, as kind of, I call it our yearly look. And it's, again, given all the subtlety that Dr. Nagpal went through, is that this may not cause, in leptomeningeal, we do think most people have symptoms, but brain metastases definitely do not have symptoms many times. Our general approach is anything feels a little off, we take a look. And so what I mean by that is, and the reason we actually focus more on the targetable things is that while the targetable mutations have more targetable treatments, they actually have a higher incidence also of brain metastases. And so anytime someone has a few lymph nodes even growing and it doesn't look like a significant growth of the cancer, we actually do an MRI brain for restaging. And so hopefully that answered kind of the spectrum of how often we monitor.
Definitely. And it also brought up another question someone asked. So they did ask about cancers with no known mutations and how they're impacted. I know you touched on that a little bit, but do we have any data on the prevalence, or do we know how likely it is? Or really, I know you said it's mostly seen in people with targetable, but what does that look like for no known mutation?
So the data that we have is just more sparse, and it's not collected as well, but we do have some data for um, for immune checkpoint inhibition. We have a little bit of data for SASI and Dato that is now, I think, is going to be trickling in. And truly, I think that you're going to see more data the more we get our hands on these drugs, to be honest, because Dr. Roy and I pay attention to that. And a lot of those publications you saw where Dr. Roy gave credit to the first author, she's on them too. So we're paying attention, and I'm really hopeful that that piece of the pie, that we're going to have better stuff coming in the very near future for everybody. Okay,
And
that's great.
Helene, and if I could follow up, I do think
Yeah.
that general estimate of about 5 to 7% is probably the most kind of closest number we have. Again, maybe an underestimate for non-mutation lung cancer, but then with that mutation, we do see a slightly higher incidence.
Okay. And then this also, you mentioned about people with brain metastases not having symptoms necessarily. If you get brain metastases, though, if you have them, does this increase your likelihood of getting LM? And is it difficult for the cancer cells to get into the leptomeningeal space? I know it's kind of pushing two together, but
I'll take that one because it's all in the brain. I think that if you have brain metastases, the cancer has demonstrated that it can go there. So the answer is yes. There are specific types and places that I get more worried about. So patients who have metastases that are in the back balance part of their brain, I worry about that a little bit more if they're in the cerebellum. If they really are abutting or just adjacent to the meninges, in some cases, I worry about those a little more as well. But there are many, many proposed ways that cancer cells enter the CSF. Some of them is directly through that extension from a solid met, but some of it is it gets there through the blood. And there are parts of the brain where that cellular exchange might happen a little bit more. We don't know how to target that yet, though.
okay. That's what we're working on, right? That's the research
Mhm.
that's happening. Dr. Roy, you mentioned a couple of drugs that are considered if and when Tagrisso is no longer effective in controlling EGFR LM. Can you talk a little bit more about what these drugs are?
Yeah, sure. So just to go back to EGFR disease, our standard is what we call a third generation TKI or tyrosine kinase inhibitor. And the most commonly, excuse me, used one in the United States is osimertinib. And so that is all the kind of detailed data we went through. when the osimertinib, if we truly think it stopped working, there's a lot of conversation of where it stopped working. So we have data from Stanford where before some of these new drugs came, we would add chemotherapy to control, let's say, cancer that's growing in the body. But if the brain is controlled, and obviously brain precious commodity, we have to keep it, we would continue the osimertinib. So we were one of the first institutions to do that approach. Now with newer treatments, the two that again is we do use chemotherapy, and chemotherapy is now being added to osimertinib frontline, meaning not until the cancer grows on that pill, but to start it front. And we do that in just higher volume disease. So if we have lots of metastases that we're dealing with. I won't go into too much detail, but even the type of EGFR mutation, something called exon 19 versus L858R, may sway us. So L858R, we may tend to use chemotherapy more. The specific combination I wanted this group to be aware of is a drug called amivantamab, which is now standard second-line treatment after progression, the cancer growing on the pill. However, there's also data frontline, and you can see how this gets complicated very quickly, where you can combine a pill like osimertinib called lazertinib with the amivantamab. And now, as creative doctors, we will use it not only frontline, where that's the data, but let's say someone does have CNS progression on osimertinib, we do think that that is a unique mechanism of action that can work even after the osimertinib. So I know that's a little bit of back and forth, but hopefully that answers the different types of medications.
Yeah, that does. And actually, it leads into another question that someone had asked about amivantamab. I'm going to try to say these names right, about the efficacy in LMD in your patients. And then also, is this something that is available to anybody, or is it only through clinical trials?
So
I
I'll
can
take that
answer.
one.
Yeah, go ahead, Seema.
Okay, so amivantamab in the United States should be available for patients at this point. The data that we have is from a phase 2 out of Memorial Sloan Kettering. It does show activity in patients with leptomeningeal disease, and I actually have had a couple of patients have pretty incredible response. So I think it is worth a try. What Dr. Roy and I didn't talk about is that that drug is not really a walk in the park. It's also a commitment, meaning patients can actually have quite a few side effects. So being in a place where you feel really cared for and someone's going to be watching to make sure you're not having those, I think is really, really important. But there is data, we're using it more. And I think, I don't know what the regulatory bodies outside of the US will do, but I'm hopeful that the data we're generating here will lead to more access outside of the US.
I know there's a lot of usually curiosity about amivantamab because it's really one of the first drugs after osimertinib that has had data. There is a subcutaneous version, and that is not yet available. I am very persistent in checking, so trust me, I will know when it's available. But it does seem to show the same, what we call PKs, like pharmacokinetic activity as far as the efficacy. So we're really hoping the main side effects we really deal with are pretty significant infusion reactions and rashes, and we're really hoping with the subcutaneous version that's going to mitigate a lot of the things we've dealt with in the past.
That would be great. We need more options. So that, you mentioned about other drugs in other countries and kind of how that, is taking shape. There's always questions about why aren't some of the trials or drugs being used in China, for example, being made more accessible or more available in the US. And I don't know if that's something you could speak to, but it comes up a lot. And I'm kind of curious if there's any answers there. Is it just our FDA and we just have to get it approved and a different
I
process?
think it's not a clean answer. It really is regulatory, and then the amount of money it takes to bring a drug to the United States from another country,
Yeah.
where there are not agreements on regulatory, right? So the FDA does have agreements with the EU and other countries, but for countries that aren't in those agreements, passing through the regulatory sometimes requires an entirely brand new study.
Yeah. Makes sense. One question we have here is patients with recently diagnosed LMD typically need to go as fast as possible to CSI proton treatment. If other systemic therapy or intrathecal approaches need to be used, what time frame should these changes be considered after proton CSI? I know it's not probably a straight answer either. It's okay.
No, I think, and the reason it's not a straight answer, I think, and you're seeing both of us say, is because every patient is very different. Some people will get through proton CSI and really not have any side effects, and their CSF will be cleared of cells.
Mm.
And then, Dr. Roy and I wonder, do we want to add toxicity if for right now things are clear, or could we delay adding something? Because all of our tools have a little bit of toxicity.
Yeah.
Or does the CSI not clear it? And in which case, what do we follow with? How does the bone marrow look? If your bone marrow looks fantastic, maybe Dr. Roy goes with a systemic therapy versus bone marrow doesn't look awesome. Patient's willing to get an Ommaya. Let's try something intrathecal. So it's truly patient by patient right now, and I don't think we can even quote you data on what you should do.
Think one general approach, and I know that in a group like this, second opinions come up, I'm sure, quite a bit. And, I encourage my patients to, of course, go get second opinions. And one of the, I don't want to call it mistakes, but one of the trends that I sometimes am a little cautious about is that while there's all this exciting drug development in general with lung cancer, we truly, unfortunately, do not have 10 or 20 effective drugs. And so we are also really cautious about not changing things too soon. I know that sounds a little maybe strange to say, but really proving that something is truly not working is really important for us. And at Stanford, we are kind of known to be creative, I would say, in like really making sure, like, let's say 80% of the disease is actually well controlled, then we don't want to change that systemic treatment. And so that's one common theme I've seen come up when I do second opinions, to say, okay, well, like, let's actually double check that. Let's biopsy it. We didn't talk about liquid biopsies from the blood. Just for time, but just really kind of trying to make sure we truly understand what's going on, and then not also jumping to say, okay, well, there's just this new medication available, so let's just change to that.
Mm-hmm. That's great. And I think it also emphasizes the importance of finding somebody who has experience in treating leptomeningeal metastases, because not everybody is aware of all these drugs and the way that they work together. And so you two are a great team. Um, if if you do end up using some of these drugs and your LM resolves and you have no evidence of disease, can it return? Yeah.
Yeah.
Okay, because that's come up a lot for people as, being out a few years, it was resolved with treatment and questioning whether it can recur or they're now
Yeah.
clear.
And I think it's a really hard question because we're just getting to the point where Dr. Roy and I may have 5, 10-year survivors from ALK positive disease in our clinic. And the answer is we don't know. So we have good relationships with these patients we've known a long time. And we say, okay, how are you feeling on this? Should we lower the dose? Should we take a break? And the answer isn't known right now.
Okay. Someone asked if you could talk a little bit more about pemetrexed that can cause white matter disease. Is that something,
Yeah.
Dr.
I can do that one. But I will say white matter disease can be caused by a number of treatments to the brain. So I didn't mean to single out pemetrexed. It's more that that's just newer data. So a lot of our treatments can cause white matter disease. In fact, radiation almost universally causes leukoencephalopathy or white matter disease with time after radiation. So at 12 months, most of my patients will have that. Methotrexate given intrathecal and IV, both can cause leukoencephalopathy. It's just to say that pemetrexed also can. We don't see that as much with drugs like topotecan or Herceptin or rituximab, some of these other drugs that we put in there, and it's probably based on the mechanism of action of the drug. So methotrexate and pemetrexate are actually kind of partially related. They're folate inhibitors, and brain likes folate for for keeping healthy. So I think it's just something that we need to keep in our minds when we talk about potential therapies, because we don't want to, for example, I think about whole brain and then pemetrexed, or whole brain and then methotrexate. That might be more toxic than we even have data for.
And I think that's also where there's so much confusion of symptoms of the disease versus symptoms from the treatment. And that's always difficult for patients and caregivers to make sense of. And I'm sure also for doctors in some way too, right?
Not easy for us either.
Yeah. So we did talk a little bit about how to monitor if you're looking for LM and you know, are stage 4 lung cancer patient or survivor. What is the surveillance approach to determine the effectiveness of treatment for LMD?
I can take that. We use all of the above that we've already talked about. So we, of course, want to use MRIs. Those hazy spots that Dr. Nagpal showed hopefully do get lighter and sometimes go away. We don't tend to use cytology, I would say, as often in routine surveillance. But if we especially had positive cytology prior, that's another surveillance mechanism. And I know this sounds again so non-scientific, but we use people's symptoms. We truly do. So we currently have someone that Dr. Nagpal and I are caring about, where we are always almost trying to like explain away the symptoms. We would say like, oh, it's, you know, it's not that bad, like it's okay. And then we honestly guided treatment based on symptoms. And so even if someone feels fatigue, we really ask people, I ask people to keep symptom diaries, just like physical diaries of like, oh yeah, like my right side of the chin was hurting, and that's different than the frontal headache I have when I get chemotherapy. And so it's really, really symptom directed as far as when we escalate. And we still, of course, will do that MRI and CSF. But I hope you take that message away from us, is really it's guided by symptoms.
And I saw a quote this week at the Snow ASCO conference where someone said, a good physician treats the disease, a great physician treats the patient. And I think that's kind of what you're saying is, you know, really looking at the symptoms and really understanding the patient and what's the best thing to do for that patient. We have a question about, we just have like 1 or 2 more minutes for questions. Can brain mets that have resistance mutation migrate back to the body? Not sure.
I don't think we know, but I think the potential is yes, right? Because then you kind of assume that there is free flow of these cells. They're migratory by nature. That's how they got there in the first place. But I can't say that that we see it all that often.
I guess I'll take that one step in a different way, is that with some of the testing with the DNA mutations, that's been one very big limitation for us, is not being able to do routine testing for these mutations we're talking about in the CSF to kind of confirm. We do think of it all as one disease. So it is, you know, all connected. We've been able to do that in a few cases recently, and I hope that technology will again really clarify. I think what this question's getting to is like, why is this part of the body acting differently with this disease than the rest?
Okay. If progression does not show MET amplification while on Tagrisso, what is the benefit or reasoning to switch to Amy-Laz combo? Is there benefit?
Yeah, I can take that. So the reason this is being asked, I think, is that, again, amivantamab targets both MET and EGFR. And so before we actually had what we call the Mariposa study data and the Mariposa 2 study data, feel free to search those, then we actually were selecting more for MET amplification and MET mutations, mostly amplifications. And that, just as a brief explanation, that is one of the most common kind of bypass or resistance pathways once that osimertinib for EGFR disease stops working. However, with the more recent data, it's been fairly compelling, actually, regardless, I would say, of MET. So even though if someone did not have that MET IHC or staining, we do not exclude the option of amivantamab plus lazertinib. For example, there's data for TP53 mutations, which are fairly common, but usually suggest a more aggressive disease biology. There is data for TP53 mutations, regardless of MET, for that combination. So hopefully that answers a little bit of the question.
Thank
We
you.
also think
We are
that MET amplification may be more common in brain as well. So it's
Okay.
another reason not to exclude it.
Yeah, and then someone did ask, and I know this is not a question that's easy to answer, but a current median overall survival for LMD. And I think, I was going to ask you guys to share last words. We have just a minute, and I want to be able to wrap up, but if there's anything you want to say about that. I mean, I think it's
Yeah,
changing.
that paper that we presented was from 2014. Okay,
Yeah.
and showed our median OS there is about 12 months. I do think the bar has moved.
Yeah.
Maybe Mohana, you and I need to go back and look and see
Yeah, we have to
how
come
we're
up with
doing
new
here.
numbers. But that's why we're all here, right?
Yeah, I mean, I think the bar has moved. I think it's maybe out past, it's more like maybe 15 to 18 if we really have creative care for a lot of patients and we're creating more access to these drugs. I think it's going to keep going out.
Yes.
And I am really excited about what's coming on the horizon.
Perfect. Well, that's a perfect way to end. Thank you all so much. I really hope that this was helpful for everybody, that you're leaving today feeling more informed. I want to say thank you to our wonderful doctors, to our amazing producer, to all of you, our audience members who are with us today. Please be sure to follow us on social media. You can see all of our handles here and sign up for our newsletter on our website, lmcancer.org. So you can stay up to date on all upcoming events. We have a number of webinars on the horizon. And this was recorded. We will be sharing this so you can take a look and revisit. So thank you again, everyone. Have a lovely day. Thank you, Dr. Nagpal. Thank you, Dr. Roy.